Hello, everyone. Welcome back. In this video lecture, we're going to talk about HCCs, which are popular in Medicare Advantage plans, and the Marketplace ACA plans. So let's have a look at HCCs. And again, we're talking about HCCs here. So let's take a look at these hierarchical condition categories. I'd rather say HCCs. And we'll talk about the role in reimbursement and how they adjust payments based on the patient's health status and complexity. We'll talk about what a risk adjusted factor is, also referred to commonly as the risk score. And risk score, how the intent is that the sicker a patient is, the higher the risk score, the higher the health plan gets reimbursed by CMS. And it relies on accurate ICD-10-CM coding and definitely has an impact on healthcare operations. Also supports healthcare quality measures and results in better audit defense and improved documentation and billing. So what are HCCs? They're used primarily in Medicare Advantage to adjust payments based on the patient risk and complexity, based on the premise that the sicker the patient, the higher the risk score, right? So they basically, you can think of them in some ways like DRGs, except what's different about them is they're cumulative. You can have cancer, diabetes, and other different types of things, and they're cumulative, where with MSDRGs, you have the principal diagnosis and you can only have one DRG per hospitalization. And again, as we talked about, the higher risk score means that there are greater resources needed that results in increased payments by CMS to the health plan and ultimately the provider. It incentivizes accurate coding, right? So things that we used to just hear hospital coders say, well, if it doesn't change the MSDRG or the DRG, I don't really need to worry about it. But now we need to capture everything and make sure that it follows the MEET acronym, the monitor or manage, evaluate, assess, and treat. And now we're seeing versions of this, just like we saw in the 1980s, where DRGs went from just being used for Medicare patients to all payers refined and PD DRGs and some of these other things. We're seeing these HCCs come into the ACA marketplace plans and others. Let's compare fee for service with HCCs. Both use ICD-10-CM and they require medical necessity, but they're different. With the fee for service structure, it reimburses providers for coded services. Hospitals are reimbursed based on DRGs that are focused on the principal diagnosis and comorbidities. HCC based reimbursement doesn't care about volume, it uses the risk score, right? You get the same risk score whether the patient comes in 50 times in 1 year or 10, right? It's the risk score that reflects the patient complexity that determines the reimbursement. The incentives and documentation for fee for service, the big key is volume. Every time you go to the physician's office, there's a coded service. It maps to a fee schedule, right? And then the provider's office gets paid, right? HCCs emphasize comprehensive documentation and risk adjustment, right? So if you can get a nurse practitioner or a PA to manage a heart failure patient and keep them out of the hospital, keep them out of the doctor's office, that's an incentive for the health plan. And then both systems use audits, but the HCC audits are more focused on longitudinal disease management accuracy. So in other words, we're looking at all these conditions that come into the health plan in the course of a year, as opposed to just a specific episode. So you can kind of look at it this way. with the payment model, traditional fee-for-service providers get paid by volume, as do hospitals, right? Providers may get paid for every service that maps to a fee schedule. Hospitals get paid on the basis of MSDRG each time the patient is admitted to the hospital. Where the Medicare Part C and HCCs, it's based on the risk score. It's all about the risk score, right? And then the payer or the managed care organization pays the physician's office based upon what their contract. It could be a percentage of what the health plan gets paid per member per month or what have you. And we'll look at a few examples in just a little bit. With the fee for service model, the more services, the more visits, the more tests, the more procedures, the more the physician's office gets paid. In the hospital setting, the more admissions, the more revenue, right? With HCCs, it kind of incentivizes coordination of care, chronic disease management, and preventative services. Medical coding is important to both models, but coding supports primarily claim submission and payment for any services that are rendered. With the HCC model, coding reflects patient complexity. It should support the risk score and the quality measures and audit defense that involve that. And the documentation requirements in a fee-for-service model supports billed services. It's not really interested in anything else outside that one hospitalization or medical office visit. Where the fee for service, we're looking at comprehensive, accurate, and specific documentation demonstrating the management, evaluation, assessment, and treatment of patients. And again, payments based on services provided in DRGs, focused on the fee for service. The coding should support that, right? And it's focused on that episode of care, right? Each hospitalization, there's payment. Each service that a medical office does, there's some sort of payment. So let's take a look at some of these. Again, so with Medicare Advantage, we talked about it's based on the risk score, but when we calculate it, the patients have to be seen at least once a year and have their condition monitored, evaluated, assessed, and treated. And the next year, the process starts all over again. And the is another thing that's different from DRGs, conditions with a few exceptions can be cumulative, right? So you don't have to really think about if somebody has cancer and they have diabetes and they have hypertensive heart disease, all those are reimbursable HCCs. We should be coding them. And the idea is if we're managing these things before the patient's hospitalized, it results in lower resource allocation, right? And we'll get into this in the next slide, but the payment formula is it's the county base rate. CMS gives each county a base rate and you multiply it times the risk score. And then there are a few little adjustments that are done for coding and what have you. But for the most part, it's basically the county base rate times the risk score. So let's take a look at one. We have a healthy 66-year-old with no existing medical problems. He enrolls in a Medicare Advantage program and has a base risk-adjusted factor risk score of 0.435. Patient lives in Lane County of Oregon and has a Medicare base rate of $1,035 per member per month. Medicare will then pay the health plan the base rate times the risk score. So in this case, it'll be $1,035 times 0.435 is going to be $435 per member per month. All right, now our patient is diagnosed with Crohn's disease, which falls into HCC 80 and has a risk score of an additional 0.550, and hypertension, which is not a reimbursable HCC. Remember, there are over 70,000 ICD-10-CM codes, but only about 14,000 that map to reimbursable HCCs. So the risk score in our patient, we increase by 0.550, but we don't get any increase for the hypertension. So now the risk score for this hypothetical 66-year-old changes to 0.985. So that will boost the reimbursement to $1,019.48 per member per month, or 0.985 times 1,035. Here's the effect of where coding accurate ICD-10-CM codes matter. Let's say the hypertension was miscoded and that instead this hypothetical patient had hypertensive heart disease instead of hypertension. What is this miscoding going to cost the health plan? It's going to cost the health plan a lot because hypertensive heart disease is categorized in HCC 238. It has a risk adjusted factor of 0.320. So now the overall risk score goes to 1.305. If we multiply 1.305 times $1,035, we have $1,350.68 a month. So a pretty significant increase. So again, we want accurate coding because we want to capture all the relevant diagnoses that reflect how sick the patient truly is. So we get an accurate risk adjusted factor, also known as risk score, right? And then these this comprehensive coding and documentation is useful in defense audits, demonstrates medical necessity using the meet criteria we talked about. Inaccurate coding, on the other hand, will lower the risk score, will reduce reimbursement for healthcare providers and the health plans. And then documentation requirement. We need to manage, evaluate, and assess and treat everything that's going to add to the risk score. We can't just drag things in like you can on an Epic electronic health record and just mention it, copy and paste something in, and expect that to work. We actually have to be addressing that. That could mean sending a patient for a referral, doing an exam, ordering tests, evaluating tests, or what have you. And again, each qualifying diagnosis, in other words, each reimbursable HCC increases the risk score. Certain diagnoses, like we've just seen, like Crohn's disease, increase the risk score. Others, like hypertension, do not. And again, the payment is made to the health plan per member per month, and then that gets a percentage paid to each medical office, right? And the importance of accurate coding, coders must qualify and make sure that the diagnoses that are submitted are supported by supporting the codes that they pick up for reimbursement. Again, as we saw this, consequences, reduced reimbursement. Not only that, it is non-compliant, and that as a result, both the provider and the health plan are getting much less reimbursement than they're entitled to. And that's all I have for you. Thank you for watching, and we'll see you online. Bye now.